Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. For this episode of the Interventional Glaucoma podcast, we're heading back to the European Glaucoma Society Congress in Dublin to join hosts Dr. Karl Mercieca, Mr. Gok Ratnarajan and Dr. Miguel as they discuss glaucoma management 5 years from now. Let's listen in.
Okay, welcome to the Interventional Glaucoma podcast brought to you by Elios Vision. I'm your host, Karl Mercieca, and today we are joined by Dr. Miguel, who works currently in France, and Dr. Gok Ratnarajan, who works in the UK. And we're going to explore, try to at least, where we will be in 5 years' time in terms of glaucoma management and treatment. So we all know that glaucoma is a big problem. The prevalence of glaucoma worldwide is rising. 76 million a few years ago, predicted to be 111 million in 2040. And of course, the population is aging. People are living longer and living better. Of course, visual impairment and blindness would have a huge impact on these people. So when we're planning healthcare, when we're planning policy, these are really important factors to bear in mind. And this is not just for us clinicians, it's policymakers, politicians. It's also about the economics and the cost efficiency of things. So of course, with early detection and potential treatments that reduce the burden, we can perhaps not just save vision, but also save money, which could be used for other diseases and other problems. So during our discussion, we're going to touch on how the interventional glaucoma mindset could address this situation. And we'll try and explore some of these therapeutic approaches that may follow from this. So I'll start with Anna. Anna, welcome to the podcast. What do you think are the biggest challenges regarding glaucoma care in your country?
So first of all, hi, Karl. Hi, Gok. It's a pleasure and an honor to be here speaking about glaucoma and speaking about this very important issue. For example, in France, where I work, despite being a developed country, there is still late diagnosis. So we still have this 50% patients undiagnosed. And although, for example, every appointment is reimbursed and all exams are reimbursed, but patients are just presented late because there's a very big lag to the first appointment. So there's a difficulty in access of care. Despite having appointments, we have many patients that are just not coming and they present when they have symptoms. So as you know, glaucoma is completely silent. It's a symptomatic disease, and this difficults the diagnosis when we have some lag in the care. Afterwards, in terms of medication, they are partially reimbursed, so this could be also a difficulty. And in terms of surgery, the MIGS devices, there is only one that is currently reimbursed, and for the legs, there is currently one reimbursed. So we do have some important points to work on.
Okay, so let me pose the same question to Gok, but I'm going to come back to you later about the problem with access, for example, and early diagnosis. But Gok, in the UK, is that sounding similar, what's happening in France, or is it somewhat different?
Yeah, hi guys. Karl, thanks for the invitation. Anna, great to be on another podcast after our last one. Yeah, Karl, we've had this discussion before, and sort of echoing what Anna was saying, early diagnosis is still the key, right? We know now with all the treatment options that we have, whether it's drops, preservative-free drops, SLT, MIGS, or the evolution of filtering surgery, that we can now take control of glaucoma if picked up early. And early diagnosis is the key. Anna picked up on it, the silent thief of sight. So early diagnosis in the UK remains the biggest problem, I would say. Second to that is how we manage those surging numbers that you talked about in the introduction. We have limited ophthalmologists in the UK, and I think we are starting to embrace working with other colleagues such as optometrists, orthoptists, nurses, and technicians to deliver a lot of that care. So consultant time can be solely focused on those with rapidly advancing disease, with high risk of blindness, spending more time in theatre, in the OR, doing the surgeries for these patients. So the organizational shift has improved in the UK, but I think we've still got some way to be able to tackle the huge demand that's there.
And Anna, so back in France, do you have support from healthcare associated sort of professionals, so non-ophthalmologists, optometrists, nurse practitioners, orthoptists? Is any of that Gok's mentioned available for you?
Slightly. So there has been improvement. We have more opticians referring to us and measuring the IOPs regularly, for example. So this increases chances for patients. We have orthoptists that now are able, a little bit as optometrists, the orthoptists are now able to see the patients independently and do, a screening, and then they'll refer to us when they feel that there's any particular concerns. Now we also are having more and more telemedicine. So for example, I was here in the Congress, and some days ago, I had patients that went to the orthoptist, and later, yesterday, I was reviewing their files. So this is very, very interesting, because in very isolated towns, patients have a little bit better access to care, and these telemedicine offices are enabling me to detect only the patients that need to come to my office. So there has been improvement, yes.
Okay, so what you're mentioning is, of course, very helpful once we have the patients in. But you both mentioned that diagnosing those people, or even just getting them to have a check for a diagnosis, is the problem. We also know that we can do so much for them early on in the early stages of disease now, and not just with drops, but also with minimally invasive surgeries. So it's very frustrating to know that we can do so much, but we don't know where those people are. So as Anna kind of alluded to, we're actually in the European Glaucoma Society Congress here in Dublin, and we're surrounded by loads of colleagues, and some of us here might actually have the beginnings of glaucoma, but we have no idea about it. We might be lucky because we sit on an OCT, get a scan and get diagnosed, but most of the people have no idea about glaucoma. And how do we get them in? Is the idea of screening an issue or a problem? Maybe in the UK, we'll start with there, and then France. And I know you've both had experiences abroad. We can talk about that as well.
Yeah, it's a great question, Karl. And I've done some research as part of my MD, looking at sort of health pathways. Screening has to be cost effective, and the prevalence of glaucoma is still quite low. So I think widespread screening will not be cost effective. I think targeted surveillance is the way forward. So picking those that we know are at risk. So those who are older, those who have a family history, those who are myopic, for example. And I think targeted surveillance would yield us the best results in terms of case finding. It does raise the other question, sort of spinning it on its head. If we do find a lot more patients with pre-perimetric glaucoma, can we manage these patients? Is the resource best focused there, rather than would that take away resource from those that are more rapidly progressing? Because ultimately there's only an infinite resource, whether it's human resource or economic resource. So it's a difficult one to know. But of course, you would still want to diagnose these patients at an earlier stage. But for me, targeted surveillance would be the most economic and viable option.
Yes, absolutely. And also increase education. So now we have a population that is more and more informed, more on social media, more on the internet, and we can take advantage of that to try to educate people, to try to explain that glaucoma is a silent disease, do your checkup, and we can have more instruments to help us there. And as for screening, yes, in a high-risk population, we can increase that. But before that, we need to just give them awareness, bring them awareness about this disease.
So it's very interesting you talk about patient being more educated, more informed, because they are. And I'm based in Germany now, like Gok. I was in the UK for many, many years. And then moved to Germany. But in both countries, over the last few years, I've realized that patients come to you, they've read up on stuff, they know about the latest devices, and they've read studies, etc. So patients, in a way, are becoming more demanding. So once they come to us, and then if they're unfortunate to have glaucoma, then they actually sometimes demand things. How do you manage that? So if someone comes to you, Go, with, downloaded the latest paper from me, for example, on device A, and you do device B, for example, but the patient actually also read about device C and wants that. How do you manage that?
Well, if it's a paper by you, Karl, I'll obviously follow that. So that's a bit of a no-brainer. But it's true. Patient empowerment, patient demands are going up, and so it should. I think that's a sign of the progress that we are making in glaucoma as a whole. So I think that's a positive metric and indicator. But as you said, ultimately, as the clinician, we need to do what we feel is best for the patient in a joined effort and explaining that to them. So with so many treatment options now, it can be a bit of a jungle. And it's sort of spending that time with the patient to sort of say, yes, you may have read about this type of technology or this type of treatment, but understanding whether that's most applicable for them. And I think generally with the patients, if you spend the time to explain it, that treatment X, though has been published or has been in the news, would not be the best one for you, they generally accept that.
So Anna, I'll continue the same question basically, but in a way taking it further forward. So when people come to you, in the past, perhaps people looked at the doctor as the professor and who knows it all and that trust, and you'll just do what they tell you. Now it's very different, isn't it? So do you think people are accepting of practices in the past? So if you are not offering the newest stuff, do people accept that? Are you looked at as someone maybe who's not in touch? Or perhaps maybe in France, they still prefer the old methods?
So there's actually a mix. We do have a very diverse population. We have some that want the non-paternalistic medicine. You're the doctor. You're the one who knows. So decide for me. But we have more and more a population that is educated. And as God said, there's the good, the bad, and the ugly in that, in which there's so much good that patients are finally trying to understand their disease, their treatments, trying to participate in their treatments. This is great. But let's not get to the bad and the ugly, which is when the patient just wants to decide his treatment without listening to us. But as Gok said, I believe that if we take the time and if we develop the relationship, and it's so important, this trust, this relationship, doctor with the patient, and our evaluation, scientific evaluation, and the human aspects, I think they will feel that among all of these choices, we really believe this is the one that will give you more probability of success and less risk. So I believe this is the right choice for you. And when we say that in these terms and we explain the advantages and inconvenience of everything, the patient finally trusts us.
Trust for, as glaucoma specialists, probably compared to any other subspecialty in ophthalmology, we need to build that trust and that rapport. Yeah. And I think once you have that, you can then really start the journey, right?
Yeah, I agree. And I think spending that time, that extra time with them, especially in the beginning, to gain that trust really makes a difference. Now, we also know that minimally invasive glaucoma surgery, or MIGS, of course, has demonstrated significant efficacy when it comes to reducing pressure. And people come to us nowadays with the expectation of having perhaps a MIGS because they read about it, they know about the safety profile, they know and read about the risks of traditional glaucoma surgery. And of course, we're not saying that all patients would benefit from MIGS. We're not saying that for perhaps much more complex cases, you have to do traditional glaucoma surgery straight away. But by and large, there's a large number of patients who would definitely benefit from MIGS. And we've seen the emergence of different types of MIGS, including trabecular meshwork procedures such as ELIOS. Now, the scope of this podcast today is to try and take us 5 years from now and think of the scenario in 5 years. So do you think that a trabecular meshwork approach will prevail and that in 5 years' time, that will be the most appropriate MIGS to do? Go.
Yeah, great question, Karl. I think with everything, there has to be a balance. I don't think it's about one prevailing over the other. I think it's important to push the boundaries on all the surgeries. I think we need to continue to evolve our filtering surgeries, our techniques, our safety on those surgeries, because we will always need the option of a filtering surgery in some patients. For those that are having mild to moderate disease on one or two medications, out of the MIGS space, I think the trabecular bypass option is a bit of a no-brainer in terms of going to first. And we have so many options within that space, whether you are bypassing, whether you are stenting, whether you are dilating, whether you're deroofing, whether you leave a device, whether you don't leave a device. So with all those options there, coupled with the speed of the surgery, the safety of the surgery, I think trabecular MIGS will remain in 5 years' time the main form of MIGS. But filtering surgery should not be overlooked for those that do need it.
Absolutely. I completely agree with Gok. I do believe trabecular meshwork procedures will increase, namely because we will be more attentive when there is a cataract in a glaucomatous patient. We should, every time that we have that indication, be aware of trabecular meshwork procedures. So Phaco Plus, whenever we have a glaucoma patient with cataract, will decrease their IOP spikes, will improve their chances of success in the future, and perhaps even decrease the progression in the long run, and perhaps even make us have to do less filtering surgery in the future. So I do believe this is a very interesting option for the future. For Ilios itself, the fact that it's stentless could be an advantage. We don't know yet. We need more evidence, of course, but we're sure we won't have any erosion, right? And trabecular meshwork procedures, once more, they have such a good recovery and quality of life after. We still need to quantify that scientifically, of course, but we do have a faster surgery, faster recovery, and good results. So I believe this is a very good option in our arsenal.
Yeah, no, I totally agree with you. And you mentioned a really important thing, of course, the combination with cataract surgery. And this is the whole mindset of interventional glaucoma, isn't it? That we want to intervene earlier to prevent problems down the line. And I just find it these days that if you've got someone who needs a cataract operation and they either have ocular hypertension but are using drops, or they have very early glaucoma and using drops. And for me, whether it's 1 drop or 2 drops or 3 drops, I find it's an absolute shame not to do a MIGS at the same time once you're in the eye. So what's your experience? I'll start with you, Anna, because you've mentioned it, combining phaco with MIGS. But how has phaco MIGS changed for you personally since you came back from Canada? I know you spent a year with Ike Ahmed. Yeah. And then how has it changed your practice over the last years, and how will it change the next 5 years for you?
So honestly, it has been a revolution. I really love performing trabeculectomies and really need to do them right and to follow patients afterwards right. But trabeculectomies come with a cost of decreased predictability. There will always be patients that will have major complications, and we cannot predict which patients will be. In the most part, at least. So this is very important to have a less risky alternative for less severe patients. So in mild to moderate patients with controlled glaucomas, absolutely. In mild patients with high IOP and controlled glaucoma, we can still perform MIGS. So it really changed completely my perspective. So I'm operating earlier, performing cataract with MIGS earlier.
Yeah, and I agree. I think, going on to the second part of your question there, Karl, how do you see it evolving over the next 5 years? Obviously, when we look at the big RCTs, you look at that whole cohort of patients. Within that cohort, you have some super responders. And then also within that cohort, you have those that have a more modest response. And I think what we'll see the evolution over the next 5 years is a better understanding when we have a patient in front of us in clinic. Are they more likely to be a super responder? And I think if that's the case, we will probably intervene earlier. If they have certain factors that they may not be such a good responder for trabecular bypass surgery, we may not offer that at all and go down another route. So I think knowing our patient and knowing their probability of success is where the evolution will be in the next 5 years.
So Gok, you really touched on a really important point here, and I think I'm going to be bold here.
Yes, you are.
Of course. Bold and beautiful. Yeah, thank you. Thank you very much. But yeah, being bold, I'm going to say that in 5 years' time, we will have a diagnostic test, hopefully, or at least a good indicator of which patients do well. We already have some sort of algorithm in our heads. We know which patients will probably do well. We know which ones will absolutely not benefit, and the ones that don't need a MIGS, etc. But we are lacking that, and I really hope it could be genetic, it could be imaging, probably more that, but I really, really feel that we can get there in 5 years.
I would even go further, and I believe in 5 years, I hope that's one of my dreams, because everybody has a phone, right? So there should be any type of artificial intelligence associated with the phone and with the software to enable people just to do an eye fundus, and then artificial intelligence would interpret and would send directly to the ophthalmologist of the region. I think that would be great. I think that will happen, hopefully in 5 years, for example.
I mean, I agree. And there's so much more, like, a genetic passport. So let's say even just a simple genetic test that's available now for the myocilin gene. If you knew that someone had a myocilin gene mutation, something like an Elios laser, just making holes in the trabecular meshwork, which is where the problem is in these patients, you're on a winner. Exactly. And of course, another really potent thing about phaco MIGS is that it's been proven to work. We trained in a very traditional country, if you want, the UK, where, trabs were the mainstay of glaucoma surgery, but we haven't done many phaco-trabeculectomies, have we? And also, again, you could debate that phaco plus the bleb-forming devices, which are not really MIGS, they do tend to fail more. Whereas if you do a phaco-Elios, you actually have more confidence that you've removed the cataract and actually that the pressure is going to be better rather than worry about failure. Is that right?
Yeah, I think, Anna touched upon this before. There are two very different things. Trabeculectomy, a good filtering surgery, remains the foundation of a glaucoma surgeon's armamentarium. However, when you combine, in my opinion, phaco and MIGS, the blebs are more inflamed, and the long-term outcomes, as well as the early post-op recovery and the need for interventions, is higher. So for me, if there is time in a patient, I would rather address the cataract before creating a bleb. And, if there's an opportunity and there's a requirement, then doing a MIGS surgery is a bit of a no-brainer.
I mean, there's now even 8-year evidence for Elios, for example, on combining phaco with excimer laser trabeculostomy. With lasting IOP and, of course, medication reduction. So I feel, of course, this is a potentially very debatable concept about, okay, is it about IOP reduction, or is it about drop reduction, or is it about both? And I feel that, yes, if you're looking at perhaps studies, IOP is very important, yes. But in everyday life, we know this, we see this, that even getting people off meds improves their quality of life. It also makes people, I find it, happier. How many times do we do a phaco MIGS? They stop their drops and they look different. Do you get that feeling?
Yeah, 100%. So Anna and I and Christoph did the last episode on quality of life, and we touched upon this. And, you can do the best trab in the world and get their pressures down to single digits and control their glaucoma. But are the patients happy? No. I think you can, I've seen in my phaco MIGS patients, their demeanor, their affect, their confidence, their outlook on life, pre-op compared to post-op. It's amazing. And therefore, we've done some work looking at quality of life in MIGS. And of course, you're combining the cataract, and the elephant in the room is by removing the cataract, they're going to see better. And that itself has a huge impact on life. But that's the reality of the surgery. It's phaco MIGS. Phaco is part of that. But both anecdotally as well as the evidence that we've collected and published has shown the quality of life improvement is big and maintained.
Absolutely. We're so lucky. We have so many new devices, and we get to change the lives for better. We get to improve their quality of life. We can see them smiling in the office after, as you were saying. For example, I had a patient whose mother lost vision because of a surgery of glaucoma. And she was so scared to have a surgery, so she refused categorically a glaucoma surgery. But then later on, she had a cataract. So I proposed, why not just add phaco Alios? It's a laser. It doesn't leave any device in your eye. So she is accepted. And now I see her, and I've really made a change in her life. So that's why we live, right? So it's so heartwarming to be able to improve so much. Are the outcomes of decreasing IOP really important? They are, but are they sufficient? No, perhaps sometimes in some patients we need to improve their quality of life, decrease their burden, and maintain, obviously, not degrade their glaucoma.
So Anna, with your routine patients, so all the patients you list for a phaco MIGS, and when you talk about risks and complications of phaco surgery, and then you're adding a MIGS, do you add much? Because I'll just tell you my personal experience. That my usual spiel with a patient, what I tell them is potential problems of cataract surgery, and by adding this extra 5-minute procedure, the risks are practically the same. Okay, so this is what I genuinely tell them. What do you guys do?
Absolutely. We have evidence. We have randomized clinical trials showing that in the arm of phaco versus the arm of phaco MIGS, we didn't have more clinically significant side effects. So I do tell them that this is not clinically significant. However, I do add that there's a theoretical risk of hemorrhage, so they need to do some bed rest. My speech is very reassuring, but we always need to under promise and over deliver. So we cannot promise them to decrease their IOP or to decrease their eye drops. We can promise them that we believe we're doing a procedure that has high probability of doing those things.
So Gok, based on what Anna has just said, because they might have a little bit of high FEMA the next day, which I think is a good thing. It means you've done a good job personally. But, their vision might not be as perfect as the patient next door who's just had a phaco because they don't have the need for a phaco MIGS. So Anna mentioned something about expectations or, sort of having that discussion with the patient. I know you very well, so I know you have good discussions with your patients. So what pearls do you have for people listening out there about sort of how you manage those expectations? Because of course they want their phaco, they want to see better, but they also want their glaucoma controlled. So what do you say? What's your...
Yeah, as we touched upon earlier, all these patients have to trust you. Without that trust, it's really hard to manage their glaucoma. And I completely echo what Anna said, under promise and over deliver. I personally feel with the majority of trabecular bypass MIGS that the day one vision is similar to cataract surgery. I really feel that the visual path is not different. Obviously, if there's a lot of reflux at the time of surgery, I may specifically say to that patient, things might be a bit blurred for a few days. But my genuine belief is in the majority of trabecular bypass MIGS, the recovery is just the same as cataract surgery.
Do you see your patients on day one, Go, in the UK?
When you start a new technology or a new device, we would routinely watch them more closely. Once you've got 50 cases under your belt and you're happy with the safety, generally we'd see them around week 1.
Yeah. Anna, in France?
Same. Due to those access difficulties, I have several different offices. So according to the place of those offices, I may choose to have a post-op between day 1 and day 3.
So I think we need to sort of conclude with one really important question here, because we talked about 5 years' time, and you can sense the passion here in our conversations. But it doesn't just depend on us, does it? It depends on many other factors which are bigger than the individual clinician or even the individual eye unit or hospital. So if you were responsible, okay, for global management globally across the world, what single change would you make to improve the quality of life in your patients with glaucoma that we could realistically implement in 5 years' time? So let's start with Gok here.
I think, this is the Interventional Glaucoma podcast, and I think one thing that can be achieved in 5 years is a change in mindset for the glaucoma physician, that when you see a patient for the first time and you have the diagnosis for the first time, that you strive to manage as many patients free of glaucoma drops for as long as possible. And that would be sort of the underlying mantra behind the treatment decisions we then make.
Absolutely. I completely echo with Gok, because it's really, really important to treat well in the beginning. I would just add that perhaps educating more and enabling patients to be more screened would enable us to detect earlier glaucoma and then to intervene glaucoma sooner.
And I'll add to that we also need to educate perhaps colleagues.
Absolutely.
Because I think it's really difficult to change a mindset or a culture. And it takes guts, it takes energy as well. But I think if you present people with the facts that we clearly have also touched on, but is clearly out there as well, then changing that mindset and being much
raising
more
awareness, isn't it?
Awareness, exactly. And being sort of, trying to do something now, but then we're avoiding a lot of potential problems and also being cost effective in the longer term. In summary, I would say that we've discussed various things. We know that there are problems with getting people diagnosed, but then once we diagnose them, we can offer them a lot now. And we can do things at an early stage to then potentially improve not just patients' disease, but also their quality of life. We can also improve perhaps the cost effectiveness of treatment across glaucoma, across an eye clinic, across a healthcare system. And I think that is really, really important. I hope you got a flavor of perhaps some differences in various countries across Europe. But ultimately the goal is the same. And when it comes to convincing the bigger powers, the politicians, etc., in the end, it is about the patient. So I'd just like a final comment from you guys, maybe a take-home message from this podcast.
Don't be a passenger in this disease. Be proactive. You will win the trust of your patient. When you win the trust of that patient, we can take control of glaucoma.
Absolutely. And I'd also like to say, embrace change. So changing is so uncomfortable, but if we don't change, we don't improve. So if we can improve, we have that ethical obligation towards our patients and towards ourselves.
Okay, so thank you so much, both of you. Gok, Anna, it's been a pleasure.
Cheers, guys.
Bye. Thank you.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by MLAs GmbH, and the Fido laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.